Good afternoon and welcome to today's program, titled Opiate Addiction, Strategies for Creating Long-Term Sobriety and Increasing Treatment Adherence. I'm Gary Enos, editor of Addiction Professional magazine. Today's program is a Foundations Recovery Network webinar sponsored by Vallejo Resources Behavioral Health Recruiting. Thank you to our sponsor and to our audience for giving us your time and attention. Before we get started today, we have a few housekeeping details. Each window on your screen can be moved by clicking and dragging, or enlarged and minimized by clicking the icons in the top right corner of each window. Please use the Q&A area to the right of the slides to submit a question at any time during today's presentation. If you cannot see this area, simply click the red Q&A button. To download a copy of today's presentation, please click the link in the Resources area in the lower left of your screen. If you have any technical issues during today's program, please click the yellow Help button to troubleshoot the issue. I have a special note about CE credit. To receive credit for today's program, you must click the green CE certificate widget at the conclusion of the program and complete the evaluation form. You must watch today's webinar for at least 50 minutes in order to obtain a certificate. If you are watching today's program in a group, please download the group submission form located in today's resources list and follow the instructions. If you have any issues with this process, please do not reach out to today's sponsor, as they will not be able to assist you in receiving a certificate. Please note that CE credit is not available for the archived webinar. It is only available for the live event. You can also tweet during today's webinar using the Twitter widget by clicking on the blue Twitter icon at the bottom of your screen. Simply click the Post and Authorize buttons to log into your Twitter account and begin sharing automatically at the event hashtag #APLiveWebinar. At this time, it is my pleasure to introduce our speaker for today, Dr. Elisa Robinson. Dr. Robinson is a licensed clinical psychologist with more than 15 years of experience treating individuals throughout their lifespan. She received her PhD from USC and studied cognitive science at the University of California, Irvine. She trains doctoral and master's level students and is currently the clinical director at Southern California Recovery Centers. She served as an adjunct professor at Argosy University for more than 10 years and currently oversees outcome research at SCRC. Elisa specializes in addiction and recovery issues, relationships, anxiety, family issues, and brain behavior. She has extensive experience in neuropsychological testing and personality assessment. Thank you, Elisa, for taking the time to speak with us today. And with that, the audience is yours.
All right. Well, welcome to this online webinar, and I'm really looking forward to talking about opiate addiction with all of you out there. This is an important topic and something near and dear to my heart, and something that I'm involved in working with on a daily basis. I was really asked to give a talk about opiate addiction by Foundations probably a little over a year ago, and I think part of that is because as the clinical director at Southern California Recovery Centers, we work with men in recovery, and a large percentage of the men at our treatment center are opiate addicts. We've been doing some research at our center and have been finding that we've been getting some pretty good outcome results. And so I'd like to share with you today the research and the literature about opiate addiction, about long-term sobriety, and what I have found and what we found at our treatment center that's been working. Hopefully you will find this to be helpful. So to get started, I wanted to just give you some basic information. What recent statistics are showing that 2 people an hour die from prescription opiate overdoses. That's a lot. And that drug overdose was the leading cause of injury death in 2013. Now, if we stop and think about that, that is a big deal. That means that more people died from drug overdose than car accidents and homicide. So we have a major epidemic on our hands, and I'm sure many of you out there have heard a lot of people talking about opiate addiction. It's become a something that's been addressed by Congress in the U.S., and you hear it on NPR, and it's a big deal these days, and it is real and true that many people are dying from drug overdose. So usually when I do this in person, I'll ask people to raise their hand if they know someone who's died from opiate overdose. And it's amazing to look around the room and see how many people are raising their hands. Today what I'd like to do is for you guys to click in yes or no. Do you know someone who has died from an opioid overdose? Go ahead and click on your screen, and in a few minutes, not minutes, a few moments, I'll check in to see. Let's see. Oh, wow. Okay, so this is what it looks like. About 70% of you out there know someone who's died from an opiate overdose. That's a lot. So let's look at the statistics. The number of unintentional overdose deaths from prescription pain relievers in the U.S. has more than quadrupled since 1990. And the U.S. is the biggest consumer of prescription opiates. So we account for almost 100% of the world total for hydrocodone, and then 81% for oxycodone prescriptions. That is a lot of medication that is being prescribed. And by 2010, the number of pain medications prescribed was enough to keep every single American medicated for 1 month's time. And then just to put something out there, that this also not only affects health, but it also affects the community in many different ways, and that there's a drug arrest occurring every 19 seconds. So let's talk a little bit about opioids. There's naturally occurring opioids in the opium plant. Also, there's kratom. I'm sure many of you who work in the substance abuse field may be familiar with kratom. That's something that can be purchased at head shops, and kind of is thought to have an opiate-like effect, similar to heroin. We have gentlemen at our facility who we test for kratom in the UAs, and we've had gentlemen who've taken that and relapsed on kratom. And then there's synthetic opioids. So there's an example of some of those. And also we have endogenous opioids that are naturally occurring in our body. So let's talk a little bit about opiates and what they do and what's happening when people are taking them. So opiates create a sense of pleasure and well-being, and as so many people say, the euphoric feeling is extremely pleasing. It's a natural painkiller, and the interesting thing about endogenous opioids is that they are triggered when we experience physical or emotional stress. So even emotional stress and trauma, and we'll talk maybe a little bit more about this later, about how trauma and opiates are connected, that when people experience trauma, there is the release of endogenous opioids within the body. There's the dopamine hypothesis, and this is important to know. This is just one aspect of what's going on in the body when people are taking opiates. So this is important to know, because if you understand what opiates are doing in the body, then you can help, and in the brain, then you can help treat it adequately. So we first have to kind of understand what are these drugs doing to individuals, and then when we can figure that out and use brain science to inform our treatment. So I'm really big on talking about the brain and how things are affecting the brain, and then using that information to best gear the treatment. So opiates increase dopamine, and as many of you probably know, dopamine is related with pleasure and anti-stress. And dopamine is involved in the experience of love, of excitement, of sex. Exercise can release dopamine. Food and sugar can release dopamine. Even music is something that can release dopamine. So what we're wanting is, as individuals, obviously people enjoy the dopamine release, and what we're trying to do is to help people in recovery find healthy ways of getting a dopamine release in their body. So you'll be looking to these other things and to be doing them in to healthy degrees, moderate. And also opioids in the brain reward regions amplify the liking of sweet tasting rewards. So oftentimes you'll see clients, and I'm sure many of you who are in the treatment field have seen this as well, is that people will be prescribed opioid medications and then become addicted that way and then turn to heroin when those medications are no longer available to them or become too expensive. When I've given this talk in the past, I've had some video clips that I use, and I have some past clients who have agreed and signed releases and have been a part of this and doing some videos. I think that they really illustrate kind of what's going on for addicts during their active addiction. And oftentimes this drug use and opiate addiction intensifies over time. Individuals may start off with taking oral form and then eventually many times turn to IV. And as many of you probably know, the IV has increased risks associated with it. There's also this common misconception that if individuals start shooting heroin versus snorting it or smoking it, that they won't need as much. And oftentimes that's not the case. So they think that they're saving money by shooting it up and oftentimes need just as much to get the high they're looking for. And that opiate addiction typically intensifies over time and can have what's called a paradoxical effect in pain management, so that many people may turn to opiates to manage pain, chronic pain, or pain resulting from a surgery, and that over time the use of opiates actually intensifies the pain and makes it worse, especially once the person has been using it habitually for a period of time. And many people turn to heroin because it's easier to find and is cheaper. And as we talked about before, that IV increases risk for diseases and death. So opiate addiction, let's talk a little bit about that. Opiate addiction is defined as a chronic relapsing disease caused by changes in the brain and characterized by uncontrollable drug seeking, no matter the consequences. So let's break this down. Opiate addiction is chronic. Now, if it's chronic, what that means is that in order for individuals to get sober and stay sober, that they need to realize that this is not something that you can just go to the doctor, get a medication, and you're done. Maybe you have the flu, you go to the doctor, they prescribe something, you go home, you take it, and eventually you no longer have the flu. But this is something that is chronic and needs to be managed over time. And that mind frame is really important in helping sustain long-term sobriety. Changes in the brain take place during active addiction, and many changes in the brain may actually have been present before the addiction even started. Even back before individuals are even born, there may be susceptibilities to addiction and opiate addiction in particular. And that characterized by uncontrollable drug seeking. And what often happens is that because the opiate addiction and addiction in general, that triggers the midbrain, and we can talk about this a little bit more later on in the talk, but because it's triggering this particular part of the brain that is associated with survival, that individuals engage in uncontrollable drug-seeking behavior and end up doing things that they would never normally do if they weren't high or in their active addiction. And when individuals engage in uncontrollable drug-seeking and do things that they wouldn't normally do, it leads to feelings of shame and guilt. And then what happens when there's shame and guilt? That the individual is then more likely to use again. So it becomes this vicious cycle. Opiate addiction is associated with a high mortality rate, and generally what we find is that there's low success rates in treatment, that the opiate addiction is often chronic relapsing involved in opiate addiction. So addiction, the way that I view addiction is that it's a brain disease, that there is a stress-induced defect in the midbrain, and what you'll see oftentimes in individuals as they're getting sober in early sobriety is that their ability to deal with stress is severely compromised. Now, part of that is because they have been using for a period of time and haven't learned a lot of coping skills, but some believe that that stress-induced defect in the midbrain may have been present from early childhood or even during fetal development, so that if the mother was particularly stressed or under certain conditions, it's possible that babies are born into this world with a difficulty managing stress in the midbrain, which makes them more susceptible to opiate addiction and addiction later on. We talked about the dopamine hypothesis and that addiction is a disorder of pleasure. And what you find is that when individuals are getting sober, that there is this often extreme anhedonia. And anhedonia meaning a difficulty experiencing any pleasure. And it takes a while for the brain to reset and begin to experience pleasure again. And that addiction is also a disorder of meaning. And that's why also in recovery, it's so important for individuals to find meaning and connection. And that is the part of the brain, that's the frontal lobes, is where we seek meaning. So opiate addiction in particular hijacks the brain. And that what happens is that it triggers the midbrain, the center of the brain, the middle of the brain where survival essentially is located. Back in the days, they did studies of addiction, trying to figure out where is addiction located in the brain. And they started off using rats. And back then they used cocaine. And they would put cocaine into the rat's brain and kind of see how the rat responded. They had the rat in the cage, and all the rat had to do was press a lever if it wanted more of this cocaine. So they started putting it into the frontal lobes of the brain, like the cortex of the brain. This is the outside of the brain. It's the part that in humans, what kind of makes us human, right? And it has to do with reasoning and judgment, right? So they put the cocaine in there, and the rats didn't really care. They didn't press for more cocaine. They didn't try to get more. If they put other rats in the cage, they would play with each other. They would mate if it was, another rat of the opposite sex. They would eat their food. But they're like, what's going on? We're putting cocaine into the brain of these rats, and they're not seeming addicted. What's happening? So then they try putting it into the midbrain. They move it to the midbrain, and what happens is that those rats then begin pressing the lever and pressing the lever and pressing the lever, and they will continue to press the lever for more cocaine until they die. And it does not matter whether they put another rat in the cage. It does not matter if they have food. It doesn't even matter if they have a shock under their feet. They will not move away from the lever and stop pressing it. So what this shows us is that the addiction is really, the big part of it is located in that midbrain region. This is important. And the reason that this is important for us to know as treatment providers is because you want your treatment to address the midbrain. Now, and we'll talk about this later, about how do we get to that midbrain of an individual? How do we get that part working differently and functioning differently? How do you talk to a part of the brain that isn't even fully aware that it's processing it? There's no awareness there. And this is what's really, really important as a part of helping opiate addicts in particular maintain sobriety. So the brain has become hijacked, and like I said, people end up doing things they would never normally do. That frontal cortex decreases functioning, so you don't have like the reasoning skills, and the desire to get the drug, it feels as if it is life or death. It becomes survival, and then leads to increased shame and guilt. So this is kind of a diagram to explain that starts off with drug use, and then the person has cravings for more. They engage in desperate behavior. That desperate behavior leads to feelings of shame and guilt. And the shame and guilt is painful. And the person turns to drugs to cope with those painful feelings. So it becomes a vicious cycle. When you see this, then you can start to visualize, where am I intervening with this client? And what do I need to do to help them break this cycle? So let's talk about recovery from opiate addiction. It is really important to recognize that there's both the physical and psychological withdrawal. So the physical withdrawal keeps a lot of people in active addiction because they don't want to feel the intensity of the physical withdrawal. They fear experiencing that, and it's extremely, extremely unpleasant. But once they get past that physical withdrawal and the post-acute withdrawal symptoms, which can last for months afterwards, there is still a psychological withdrawal from opiate addiction that can last up to a year. So that acute detox can take 1 to 3 weeks. We have post-acute withdrawal, and that's what we call pause. That can be around for months after the person has actually physically withdrawn from the drug. The post-acute withdrawal symptoms can include sadness, anxiety, yawning, insomnia, anhedonia. But that emotion of withdrawal, like I said, can last up to a year, even several years. Now, if we think about dopamine and what dopamine is involved in, and we talked about that earlier, one of the things that dopamine is involved in is in love. And if we know that this drug is releasing dopamine, does it make sense that an individual would fall in love with their drug? And that when they stop the drug, it's a loss, similar to the loss of a person that they had been close to. And as many people probably can relate to, losing someone through death or through the end of a relationship takes time to grieve and to process through that. So if you put it in that context, it makes sense why individuals with opiate addiction need more time to process through and to go through the emotional withdrawal. And like I said, a grieving process. They may need to grieve the loss of the relationship with their drug. So withdrawal is physical and emotional. So what is involved in emotional withdrawal, and what are the things that need to be addressed in treatment? So for example, facing fears and insecurities. I mentioned earlier that I work at a substance abuse intensive outpatient program for men in recovery. And our program is about 6 months long. And of all the hundreds of men that I've met, and individuals in general that I've met over the years, I would say that probably about 90 to 95% of them tell me that they have social anxiety when it's come into treatment. And so a big part of emotional withdrawal and emotional recovery has to do with facing fears and insecurities. It has to do with issues of difficulty being vulnerable. As you can imagine, being vulnerable when you're in active addiction is not the way to survive, and that by being vulnerable, you can get hurt more, and many people have been traumatized, so it's hard for them to be vulnerable. But part of recovery is learning to be vulnerable. Extreme depression during detox and often after that as well. Anhedonia, grieving the relationship with the drug, learning how to socialize again. And these aspects of recovery often are not addressed when clients are on maintenance therapy. So I personally am a proponent of abstinence-based recovery, and the reason is because in abstinence-based recovery, you're able to address these issues of emotional withdrawal and emotional sobriety. There's a brief explanation of the theory that's kind of guiding the treatment that I provide in the treatment of opiate addicts is a biopsychosocial approach where the treatment modalities, so motivational interviewing, CBT and DBT, seeking safety, EMDR, and 12-step are some of the things that we will use. Family and couples interventions, of course, process groups, vocational rehab, and relapse prevention. Now, if we break this down, remember I said earlier that if the addiction is taking place in the midbrain, that we want treatment to address the midbrain. So of these, when we look at these different treatment modalities, they all have a place, and I think they're all important in different ways. But the majority of these have nothing or very little to do with the midbrain. Motivational interviewing is basically negotiating and working with ambivalence and resistance and uncertainty in sobriety, and that is addressing the frontal lobes of the cortex of the brain. CBT and DBT is teaching your cortex new tricks on how to cope. Seeking safety is addressing kind of how to help your cortex learn to get safe, in other words. Families and couples interventions, not really necessarily addressing the midbrain unless maybe it's more of like a psychodrama. Process groups can sometimes experientially address the midbrain. The two ones that, to me, I think are some of the most powerful interventions and do affect the midbrain is EMDR and 12-step. So I want to talk a little bit about 12 steps in the brain. I'm very excited about this because we don't use just 12-step in terms of the treatment, but it is a component of the treatment that we provide or that we recommend. And we've seen it for years helping individuals get sober and stay sober. We haven't always known why. Like, what's going on and why is this working? Well, there's some new research out that's kind of showing what is going on in the brains of individuals who are engaged in step work. And what they've found in this new research is that there's increased acceptance and connection. So there's increased oxytocin release. Oxytocin is the bonding hormone. It's the hormone that's released when a mother is nursing her child. It's also released under other situations. It's released during sexual intimacy, but it's also released during friendship and bonding. A hug can release oxytocin. Petting an animal can release oxytocin, and it helps individuals bond with one another. There's also some interesting research being done on the use of oxytocin to help individuals with autistic spectrum in learning to read social cues and to bond with others. So it increases social connectivity. And by going to meetings and engaging in 12-step, what we're finding is that there is increased oxytocin release. There's also this possible increase in neuroplasticity in individuals who are regular meeting goers. There is a hypothesis that there may be increased dopamine release among those who attend meetings regularly, and that increased dopamine activity would lead to increased reciprocity, decreased norepinephrine-related stress, reduced craving, increased decision-making skills, increased social bonding, and a decrease in immature defense mechanisms, for example, like manipulation and lying, that helps. So long-term treatment. Because withdrawal from opiate addiction is not just physical, but it's also emotional as well, and as we talked about before, that emotional withdrawal can last for a long time. Treatment, I believe the best outcomes are when individuals can get long-term treatment. And that in treatment, clients need structure to help them learn impulse control and self-regulation. It takes time to get clarity of thought because this brain has been hijacked. And if you have a 40-year-old man coming into treatment who's been using opiates for the past 20 years, it's going to take some time for his brain to get some clarity of thought. Long-term treatment can help set up skills and supports to allow this person to manage the chronic illness, address issues of trauma. I know that many residential and inpatient facilities are using EMDR and other strategies to address issues of trauma, but oftentimes individuals are just not ready to address that trauma during the first 30 days of treatment. And so we do a lot of trauma EMDR work in particular with individuals who are at our treatment center. That long-term treatment will help in the client's learning emotion regulation skills, easing into adult life skills. So it's recommended that the individuals have a step-down process in their treatment plan. So what we do is we have pretty intensive first month, and then after that, for the last 4 or 5 months of treatment, they're expected to get a job and be in treatment at the same time so that they have supports to help them learn how to have a job, learn adult responsibilities. Some clients don't even know how to do laundry or make their bed. They're severely lacking in adult life skills, and they need guidance and help through that process. Long-term treatment helps to develop new friendships and develop trust. So trust is a very big interest of mine and something that I've researched and spoken about multiple times. So I'll come back to this issue of trust later because I really think it's important. And that long-term treatment can also help with diagnostic clarification and appropriate medication management. Of the individuals that come to our treatment center, they typically have about 30 days of treatment before they come to us, and a large portion of them have a diagnosis of bipolar. And many people look bipolar when they are actively using, but we need a baseline of sobriety before we can really get an accurate diagnosis oftentimes. So many times if I suspect that an individual maybe really does not have a bipolar disorder, while they're in treatment, we will maybe taper down off the medication. And it takes time to figure out, is this an accurate diagnosis or not? What is the best medication for this individual? Sometimes individuals do have a bipolar illness, and that too is a chronic condition that needs to be managed over time. So long-term treatment also helps treat that emotional withdrawal that I talked about earlier and address issues of emotional sobriety. So they may have stopped using drugs, but the old behaviors can stick around for quite some time, and it's really important to address those old behaviors in order to help maintain long-term sobriety. Emotional sobriety. So what I just said is that the drug use may end, but the behaviors often remain, and that those behaviors may take longer to go away. And if you don't treat the behaviors that go along with the addiction, that there's a higher likelihood of relapse. So what's emotional sobriety? What are some of the behaviors that require treatment that often go hand in hand with the addiction but can stick around? Is lying, cheating, manipulation, controlling, codependency, chaos creating is a big one, high emotional reactivity, impulsivity. Those are just some examples of some of the issues that we are needing to treat if we're going to help individuals sustain sobriety. And underneath a lot of those behaviors is actually fear. All of this is hard work, and this is a chronic relapsing disease. So how do we keep people in treatment and support long-term sobriety? Let's talk a little bit about treatment adherence and compliance, because many individuals with opiate addiction will leave treatment, AMA, or maybe not even get into treatment, or maybe not engage in long-term treatment when really they need it. And what strategies can you use to increase adherence and compliance in treatment? So adherence and compliance, non-compliance in general, is a really big issue because it can result in major problems. Someone not adhering to recommended treatment can end in relapse, reoccurrence of illness, medical complications, death, and we also know when you look into the issue of treatment adherence that non-compliance or non-adherence to treatment recommendations across the board creates a huge economic burden to the economy and to individuals themselves. So this is not just about opiate addiction, but treatment compliance in general is a major issue. In my experience and based on the research that I've done, there's three main things that I believe are very important to increasing treatment adherence. And these are them, and we're going to go through. So trust, structure and kindness, and hope and desperation. So I said I would come back to trust, and it's a big topic. Trust essentially is confidence, and mistrust is suspicion. So the moment there's suspicion about a person's motives, everything he does becomes tainted. Mahatma Gandhi said that. Now think about this in the context of treatment of addiction and treatment of opiate addiction. When individuals come to you for treatment, the moment they are suspicious about your motives, everything you do becomes tainted. And therefore, where is the compliance with the things that you're recommending? When you tell them, I don't think you should leave treatment early, are they going to trust you? So a huge part of helping individuals maintain long-term sobriety is helping them learn to trust and creating a company and an atmosphere of trust. So how do problems with trust play out in treatment? There's lots of different ways. They may not trust your advice. They may not tell you the truth about their symptoms or let you know when they're not following through. They may think you have ulterior motives. And trust is going to be an even more important issue in individuals with trauma. The key to building relationships with clients and helping them get well. Please trust that I will show you the right screen. So here is trust, an example of trust. To me, this kind of illustrates here's a woman who is giving her full trust into this individual, and looks like he's trying to help her, but I don't know if he's going to quite make it or not. But this is what many people feel like when they're coming into treatment, especially for the first time or coming in the very first day into your office or into your treatment center. Examples of mistrust in the addiction and medical field. So again, someone may refuse to see a psychiatrist. The reason I point these out is because when these things or similar things happen in your treatment of individuals, I want you to be paying attention and be mindful of trust, because trust must be addressed in therapy. If there's issues of mistrust, it needs to be addressed, and there's lots of ways to do that. From top down, company-wide, individually in sessions, and in groups. It's a big, important topic. So here's just some examples of how mistrust in the addiction and medical field in general can play out. So a client may not open up to you when they're having urges to use or relapse. Aspects of recovery that require trust. Trusting a sponsor if someone's working 12 steps. Trusting a counselor or a therapist. Trusting the process. How many times have we said that or heard that? You've got to just trust the process. Trusting in a higher power or spirituality. Trusting others in recovery. Trusting in friendships or romantic relationships, which is important if they want to develop healthy relationships. And all of this depends on individuals being able to trust themselves. So healthy trust and learning to trust essentially is about risk-taking. In order to trust and to be vulnerable, an individual needs to learn to take healthy risks. And you can take healthy risks when you know that you can cope with emotional pain. So those two things go hand in hand. Helping individuals learn to cope with emotional pain can help them increase their ability to take risks to trust, healthy risks to trust. So for many people, I like this picture because for a lot of clients who are in recovery, they often feel like a fish out of water. And to get to that bigger bowl, to get to another life that has so much more for them, that they need to feel like a fish out of water many times, and to learn to be vulnerable and to learn to practice taking healthy risks and trusting. And it's not a perfect thing. There's going to be times when people make mistakes and trust the wrong person. There's going to be times when they don't trust and that doesn't work out well for them. But helping guide people through that process is really important. And developing resiliency. So we talked about trust and the importance of trust. And another important part of helping individuals maintain long-term sobriety is a balance between structure and kindness. So if you judge people, you have no time to love them. And the reason I put this up here is because I have struggled with this as well. That I have been in a place of judging people who are in active addiction. In my personal life, I've judged individuals when they're in active addiction, and that's before I really understood active addiction and understood addiction the way I do today. And many people still do judge addicts. That's a big, huge part of society, that people will judge the behavior of addicts without understanding. And kindness is so key to recovery, especially for opiate addicts who are dealing with oftentimes with a lot of guilt and shame and trauma and pain. But if we only used kindness, then that in and of itself is not enough. That there needs to be structure to treatment as well. So it's kind of this balance. If you overdo it with structure and you come down too hard, then you may find yourself veering too far off from kindness. And if you overdo it with kindness and you lose the structure, that's not healthy either. So this is something that, I could spend a lot more time talking with individuals who are kind of own companies or who are in management positions, because this is a really important way that a treatment center needs to be designed with this key in mind. How do we create a business that is trustworthy? And how do we create a balancing act between structure and kindness? And what I mean by structure also is consistency. So a client needs to know that if I'm vaping in group or I'm on my cell phone in group, that there's a consequence to that. And that consequence will stay the same from day 1 to day 30 to day 60. And it doesn't matter whether it's one treatment provider or a different treatment provider, that it's consistent and that there's structure. And the third piece of maintaining long-term sobriety is helping clients balance out desperation and hope. So this is something that I have learned, and I did some qualitative research among the clients at our treatment center and came up with this idea that that I think is really helpful to view it in this way. That individuals are, in order to maintain long-term sobriety, especially from opiate addiction in particular, that it's important to be thinking as professionals and as treatment providers about balancing hope and desperation. When clients first come in, they're often very desperate. Maybe they've been homeless on the streets, or they've been in chaotic living situations. They've been experiencing trauma. They have hit a rock bottom, and they are desperate to not live that life anymore. Oftentimes they're so desperate that they're hopeless. They can't possibly see another future for themselves. They can't possibly imagine a life of sobriety. They can't imagine their lives without heroin or without opiates. So oftentimes we'll see lots of hopelessness, suicidal thoughts and ideation, and their hope for the future is just not there. And I could talk even more about the installation of hope, because I have some ideas about that too. But that would be a whole other talk. But in those moments, what they need is help with hope. And as clients start to get sober, and what oftentimes we see is that 3 or 4 months down the road, they feel more hopeful. They see that there's a possibility of living a life sober, that that's even possible. They maybe even have a job. They might have some friends. Their life feels different. They have more pleasure perhaps in their lives, and maybe feeling less depressed or less anxious. They're feeling hopeful, and they lose sight of the desperation. They may take for granted the sobriety or feel overconfident about the sobriety. And in those moments, as a treatment provider, you need to turn up the heat with the desperation. So balancing those two out. If one takes over too much, there's too much desperation, it leads to relapse. Too much hope or too much overconfidence in sobriety, that too can lead to relapse. So keeping this in mind as a treatment provider can help. So let's go back to this problem and this epidemic. During this talk, it's estimated that approximately 3 people have died from opiate overdoses. And by this same time tomorrow, it's estimated that 48 people will have died. That's a lot of people. And if you can, and I couldn't put this on the screen, but if you can, look at those individuals and put faces. Because those are not just sick people. Those are real people. Those are mothers. Those are daughters. Those are fathers. Those are sons. Those are brothers and sisters. And in working with this population, it can be so hard and so devastating when we lose people that we're close to and we see people relapse or leaving treatment early or dying. And so an important part of working with this population is finding your own source of hope to keep you going. For those of you who are treating opiate addicts, don't get discouraged when clients leave prematurely. Please remember that you have still helped them and that you are planting seeds. Remember that what you do is important, that you are touching lives. Find support to manage feelings of discouragement. Find your own sources of hope and faith. When you're treating these clients in particular, it is so important to engage in self-care. And I know for me that I have many sources of hope and faith, but one in particular is a brother who is an opiate addict in recovery, who I have lacked kindness with in my past, who I have been frustrated and discouraged, and who I grieved his death for a period of time. I actually, if I ever heard the phone ring, I believed it was a call telling me that my brother was dead. But today, here he is. That is my brother. Whoops. Oh, where did we go? Sorry, guys. There he is with his wife and kid, and that is one of my sources of hope and strength in the work that I do with clients, because I see that living a different life and maintaining long-term sobriety from opiate addiction is possible. So typically at the end, I do a quiz. When I do this with a live audience, I think that it's helpful just to have a refresher of some of the things that I think are most important topics. and I will also have time for Q&A in just a few. So these are some of the things to just maybe ask yourself if you know the answers to these. What is an endogenous opioid? 2 experiences that can trigger dopamine release. And then back to that dopamine release, as a treatment provider, be thinking about things that you can do, I mentioned this before, to help increase healthy dopamine release. So for example, at our treatment center, a big component of it is learning to have fun in sobriety. We'll take guys on hikes, we'll take them to the beach, we'll take them go paintballing, to the movies. You need to find ways to have dopamine release in a healthy way. What does it mean to plant seeds? So maybe I didn't explain that enough, and if I didn't, basically what I mean by that is that although a person may leave treatment prematurely, but the things that you've said and the moments you've had with them may still have had an impact, and it may be later on down the road when those seeds come to fruition and that person's able to maintain their sobriety. So the things you have done are not in vain. True or false, opiate addiction is considered a chronic condition. True. How long can emotional withdrawal from opiates last? Give an example of how trust can interfere with treatment adherence. That's important. And what does kindness need to be balanced with? Kindness needs to be balanced with structure. And desperation needs to be balanced with hope. Okay. I believe we have time for Q&A, and that they'll be sharing some information with you about the heroes.
Yeah, thank you very much, Dr. Robinson. Great presentation. Before we get to our Q&A portion, I'm going to hand things over briefly to Leah Boone from Foundations for a few words from our sponsor. Leah?
Here at Foundations Recovery Network, our grassroots movement called Heroes in Recovery has a simple mission: to eliminate the social stigma that keeps addicted individuals from seeking help, to share stories of recovery for the purpose of encouragement and inspiration, and to create an engaged, sober community that empowers people to get involved, give back, and live healthy, active lives. Join us in this mission at our 6K race series at these locations across the country. As a thank you for your attendance today, please enjoy the discount code Webinar2016 to register for any future 6K events. Back to you, Gary.
Thank you so much, Leah. We are getting a number of great questions, and we're going to try to get to as many of them as possible. Also, to remind everyone that you can still use the Q&A widget below the slides on your screen to submit a question at any time. Dr. Robinson, we had a question that came in regarding citation on that research related to oxytocin and the effects in 12-step attendees. Do you have any author or something you can point to on that?
I do. I would have to go through. I have it on my computer, but I can send that out. I would be happy to send that citation. So if you can give me some information, then I'll be happy to send that.
Very good, very good. We had a question that came in that I thought was pretty interesting. It says, how do you deal with a client's feelings of guilt that lead them to feel they don't deserve to succeed due to the terrible things they have done in the past? Any thoughts on that?
Oh, yeah. I have a couple different thoughts. That's huge, and that is something that comes up frequently in clients. So a couple different things. One is acts of kindness and giving back. So if you can help a client get out of themselves and to do acts of service for others, what I have found that can be one of the most helpful ways for people to manage and deal with the repercussions of the feelings of shame and guilt of things that they've done in the past is really just by doing something different today. So that's a behavioral intervention. Also, another intervention that oftentimes I'll use for that is EMDR. So in helping people, because there's a trauma that gets experienced when you are the victim of trauma, but also it's traumatic to be the perpetrator of something that you have guilt and shame about. And so that too needs to be treated. So I would say, through therapy, talk therapy, through process groups and supporting, and that I found EMDR also to be particularly helpful. In terms of acts of service, to even just small things like reaching out to new people who have come into the treatment center. Or we've done activities where people will get packages of water and go hand them out to homeless people. Or we'll take people to a homeless shelter or a food bank and have people start doing some things. I mean, those are bigger activities, but small things like that I think can be really helpful.
Fantastic. I also want to remind the audience that this would be a good time for people to begin considering filling out your CE certificate information by clicking that green CE widget. We had some questions, Dr. Robinson, that came in regarding medication-assisted treatment for opioid dependence, and I wanted to ask, I'm going to throw this one out there. This was kind of sent as a comment, but it really I found kind of interesting. The person said, if medication for mental health diagnosis is beneficial and helpful for stabilization and management, why is medication-assisted therapy for opiate addiction not seen as appropriate for stabilization and learning new skills?
Oh, well, I guess it depends on what the medication is, but I'm absolutely like a proponent of many types of medication for stabilization and learning skills. And for some individuals, Suboxone or methadone as maintenance may be the most appropriate route. However, I think that the problem with those things is that you miss out on opportunities for dealing with the emotional withdrawal because you're kind of preventing some of the emotional withdrawal, and so that the individual doesn't actually get to deal with it or address those issues. But for some people, that is the best solution. So at the treatment center where I work, we don't do maintenance therapy, but we do actually use naltrexone and Vivitrol, and there's also some interesting new research which shows that Vivitrol can help increase the positive effects of EMDR because it decreases the release of endogenous opioids, and so that the individual can work through and process the trauma even better. So I found that to be quite interesting. We also use, of course, like medications, psychotropic medications that are a very important part of recovery and sobriety, that mental health and addiction issues both need to be addressed, and I'm all for that.
So you wouldn't feel then that medications should be, such as buprenorphine, Vivitrol, et cetera, should be necessarily rejected out of hand. That's not your point of view. It's more that
no.
It has to be individualized to the client. I want to make that clear because obviously a few of the questions that came in sort of referenced that, and I think maybe assumed from your presentation that you were more inclined to say MAT is not indicated in any circumstances. Or
no, I mean. Yeah, so I'm really glad you asked that question because just to be clear, that I do think that it needs to be conducted on an individual basis, like the treatment plan, and that, for example, Vivitrol and naltrexone, I believe, are very helpful pieces of maintaining long-term sobriety, and that maintenance medications for some people may be the best option. But like I said, the drawback to that is that I believe that, for example, if a person's on methadone maintenance or if a person is on Suboxone, that often what we find is that the emotional withdrawal and the emotional piece of the recovery is limited or may not be addressed as thoroughly as if a person were in abstinence-based treatment. And when I say abstinence-based treatment, I mean just abstinence from drugs, alcohol, but of course, psychotropic medications, other medications that are needed, Vivitrol, those things are used as part of that.
Got it. Thank you. That's an important clarification. Thanks so much. Another question that came in states, in your history of working in treatment with opiate clients, what is the treatment outcome and compliance for males versus females? Now, I know you said your program works with men, correct?
Yes.
Do you have any impressions, on that gender?
I think I've read research on that, and there's been some mixed results in terms of what the gender-based outcomes are, and I don't have any research that we've done specifically on that. I do find, and I know that some of the research is supported, that gender-specific treatment is helpful, and that can be more beneficial to to helping with long-term sobriety. So that's why we have all men at our treatment centers, because we believe in gender-specific treatment. But I don't have any specific references for the research on that right now.
Okay. And a question about emotional sobriety. The attendee asks, how are the issues of emotional sobriety unique to opioid addiction? Are they also present, do you find, in other addictions such as alcohol, even maybe some process addictions?
Absolutely. No, I think that the issue of emotional sobriety is present among all different types of addictions, regardless of substance or even process addictions as well. So it's very common, and most of the issues are you can see, regardless of what the drug of choice is for an individual, that we're always addressing issues of emotional sobriety.
Very good, very good. A reminder again that we do have a little time left, folks, so if you still want to submit a question, you can use the Q&A widget below the slides in order to do that. And we're getting a lot of questions coming in, so I will try to ask a couple more before we have to close here. Another question was, have you seen research regarding recreation therapy in treating addiction? Any thoughts about use of those types of modalities?
That's a really good question. I haven't seen any research on that, but anecdotally I can say that I think that it's been very helpful. It's definitely been helpful with the clients that we have at our treatment center. We have probably about almost 200 people in treatment, and across the board I would see that that's a big part of helping individuals stay in treatment and also in recovery, because it has to do with having fun in sobriety, getting a natural healthy release of dopamine and oxytocin and endogenous opioids and endorphins. So I could say anecdotally that I believe that to be very helpful.
Excellent. Another question, Dr. Robinson. When a client has a co-occurring disorder, co-occurring conditions, I assume this person probably means substance use and mental health related. Any thoughts about what should be addressed first? I think you made some mention of that in your presentation, but could you talk a little bit about sequential or parallel treatment, that kind of thing?
Yeah. I think that both need to be addressed simultaneously. I think the older way of doing things was that a person had to get sober before you would address mental health, so that an individual had to have the mental health piece addressed before they could get sober. But my belief is that if you can address both of them simultaneously, that you can get the best outcomes, that it doesn't need to be one before the other.
Excellent, excellent. And the questions are coming in fast and furious. I really appreciate it. This is obviously a topic that really resonates with the. Here's maybe a good one to close on, since we're getting close to the end here. In your experience, what is the worst part of opioid addiction? That is the factor that is the most difficult to treat or to address in treatment. Any thoughts there?
Yeah. I think that because it's triggering the midbrain, where there is not conscious awareness, that an individual can be triggered to use at such a powerful and deeply seated level. And it can be connected with so many other behaviors and feelings at such a deeply seated level, like I said, kind of out of conscious awareness, that individuals will make decisions that lead to relapse or overdose and death without really even having that conscious awareness that they are making those choices, those decisions. And that the addiction is very powerful, and that's also where, I know I keep coming back to EMDR, but in my experience, I've seen kind of that bilateral stimulation, and that what I've found is that by accessing, many times I believe that what we're doing is accessing the midbrain and integrating it with the logical part of the brain. And that's what we're looking to do, is got to integrate that middle part of the brain that is triggered so powerfully with the logical and thinking part of the brain. And that takes time. But I think that is what is so challenging, and that getting the drug or getting high feels as if it is a matter of life or death or survival. And that feeling can be at the core, in the body, at a deep level that is beyond cognitive awareness or recognition.
Well, this has been a tremendous not only presentation but also Q&A session, so I want to thank everybody involved. And I'm now going to pass along some final instructions regarding CE credit. Again, should you have any issues with this process, please do not reach out to today's sponsor, as they will not be able to assist you in receiving a certificate. To receive your certificate for today's program, you must click the green Program Evaluation widget, complete the evaluation form, and click Submit. For those watching in a group, as a reminder, please download the group submission guide and program evaluation located in the resources area and follow the instructions provided. If you're watching from a mobile device or tablet, you will need to email the help desk to receive a program evaluation and certificate. Please note that CE credit is not available for the archived webinar. It is only available for today's live event. If you have any questions about this process, please click the purple Contact Webinar Help Desk widget at the bottom of the screen. If you enjoyed today's program, please join us again on Tuesday, May 31st for our upcoming Addiction Professional webinar sponsored by Foundations Recovery Network along with Vallejo Resources Behavioral Health Recruiting. The program on May 31st is titled Accepting and Teaching Spiritual Forgiveness in Early Recovery and is presented by Alexis Thomas. A link to register for this program is located in the resources box on the left side of your screen. Again, I want to thank Dr. Elisa Robinson for an excellent presentation today. I also would like to thank Vallejo Resources for making today's Foundations Recovery Network program possible. Finally, thank you to you and our audience for participating today. We hope you'll join us in the future for another Addiction Professional webinar. This concludes today's presentation.